Hello and welcome to KCS Connects. My name is Jack Miller, one of the co-directors of Key Clinical Skills. KCS Connects is our way of helping connect you with some literature that we believe will positively impact on your clinical practice. This issue of KCS Connects looks at a study published back in 2008, and it had to do with the elbow extension test to rule out elbow fractures, multi-center prospective validation and observational study, diagnostic accuracy in both adults as well as children. It was conducted by a group of researchers from the United Kingdom and published in the British Medical Journal online. And we give you the link out to it there if you want like to resource this yourself. It is free access. Now, a little bit of background here is that elbow fractures are relatively common in a variety of populations, both adult and children, but the overall incidence of the different types of fractures does vary quite a bit, as you see in the table that we present to you here. Nevertheless, the most common types of fractures, at least in adults, is a radial head or neck fracture, whereas in children, it's the supracondylar or intercondylar type that seems to be the most prevalent, taking up at least 60% in the children and 50% for the radial head in adults. Now, a little bit more about these fracture types. In the adult population, as we mentioned, it's quite common to have a fractured radial head. Now, the mechanism of injury is typically a fall on an outstretched hand, and it's usually with the elbow in both extension as well as pronation. And there's those four different subtypes of fracture patterns, as you can see, and we provide for you there the x-rays on your right-hand side, some of the typical patterns that are seen with these radial head fractures. In the pediatric population, as we mentioned, it tends to be either a supracondylar fracture, that's the top graphic on your right-hand side, where the fracture is a line that extends transversely or obliquely through the distal radius just above the condyles. And that distal fracture can migrate quite a bit, as you see in that radiograph. And so appropriate alignment is going to be really important and good reduction. There's also intercondylar fractures where the fracture line extends either as a T or a Y shaped up between the condyles. And again, that would be less likely to have displacement compared to the supracondylar fractures. But nevertheless, the problem now is that it is interarticular, isn't it? Now, this particular case study that we're going to look at here is just a mythological one we've made up here, but one that you would see typically in clinical practice. Let's say you've got a middle-aged male that has a 3-day history of a fall off of a ladder, and it's the typical story. They're taking down the Christmas lights on January the 2nd. I leave mine up till spring. And they present with right elbow pain and bruising. Now, they did go to a walk-in clinic where they were told that they have a sprained elbow. And when they present to you, they've got a significant restriction of both flexion as well as extension, along with that pronation and supination. And all movements are limited by lateral elbow pain. Now, further background is we do have these clinical prediction rules that can be of tremendous assistance in making decisions about the need of imaging. And some examples are Ottawa ankle and foot rules, as well as knee rules, and the Canadian C-spine rules. And these are done to help reduce the unnecessary imaging that's often done for individuals that might have minor trauma to these areas. And so the question we ask, and it's answered in this paper, is there a similar type of clinical prediction rule that we can apply for imaging at the elbow? And so this particular study looked at over 2,000 adults and children presenting to United Kingdom emergency departments with acute elbow injuries. And the intervention here was they did the elbow extension test, which we'll demonstrate shortly, during the routine care to determine the need for radiography. And their outcome measure was the presence of elbow fractures on radiographs or recovery with no indications for further review at 7 to 10 days. Now, the elbow extension test that they looked at here is relatively simple. You just simply passively extend the elbow. And if the patient won't let you do it, then because of reproduction of their typical elbow pain, then that carries with it really low specificity. But if you can perform full extension of the elbow with no significant reproduction of pain, carries with it tremendous levels of sensitivity at 96.8, effectively ruling out the likelihood of fracture and therefore the need of further imaging. Now, the opposite, which is not looked at in this particular study, is the elbow flexion test, where you simply flex the patient's elbow. And again, it's this inability to fully flex the elbow compared to the contralateral side because of reproduction, other typical symptoms of complaint. Now, in this particular case, though, it's got high levels of specificity where you can rule in the likelihood of a fracture and therefore, again, corroborate our findings for the need of imaging in this particular case. Now, a little bit of a tip here about imaging at the elbow is that there is a fat pad that surrounds the elbow, both anterior and posterior, and it's normally not seen on a lateral projection radiograph. It's hidden from view. But if there's been a subtle fracture at the elbow, whether it be the radial head or intercondylar or supracondylar fracture, even quite a subtle one, now because of the joint effusion, that now tends to push the fat pad out of its normal bed, creating what's commonly called the sail sign, because it kind of looks like the sail on a sailing boat, this triangular sort of dark space. And if that's seen on a plain film radiograph, then again, there's high likelihood that there's an underlying fracture. Now, if you'd like to learn more about imaging for physiotherapists, come visit us at Key Clinical Skills, where we have our imaging foundations, spine, extremity, and utilization courses. These are all online, self-paced. You study at home in your PJs at your own pace that you wish to. We provide for you over 60 hours of learning and a 850-page downloadable handout that you can keep for your ongoing reference. And there's a link out to our site there if you'd like to come visit us and learn more about imaging for physiotherapists. Thanks for your time and attention.